Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today, a little bit of a bonus here. It's not an official podcast, but, it's holiday time. Let's have a little gift. And the gift today is a lecture from the REANIMATE 9 conference, the Endovascular Resuscitation Conference, the ECPR conference we do every year in San Diego. And every year we have a grand round speaker. And this year it was Jason Bartos, who is, I think, one of the foremost people in the world on the management of post-arrest ECMO and how to get patients from the point of death to leave the hospital alive. There's no one else doing it at as high a level as Jason Bartos, along with his partner, Dimitri Yiannopoulos. The two of them together have the best ECPR neurologically intact survival rates in the world. How do they do it? Well, that's what this lecture is about. This is, in my opinion, the best ECPR lecture out there right now. It doesn't mean there can't be better in the future, but in terms of 2023, December, this is the best ECPR lecture that has ever been given. And it is given by someone brilliant, Jason Bartos. He is an interventional cardiologist. He is a cardiac intensivist. He has both. That's what you need to have the amazing save rate. So you're going to hear Jason Bartos give the Minneapolis experience on extracorporeal CPR. It is completely practice changing. Even if you don't have an ECMO program, just hearing about what can be done will change your mindset. Now, before we jump in, if you want to learn directly from the best people in the world how to do ECPR, concentrating on those first few hours, how to do resuscitative ECMO, how to do a technique that will take a patient from death's door, pericode, massive PE, to completely stable. Patient who is in cardiac arrest, not going to survive, past the point where ACLS is doing anything, walking out of the hospital alive. If you want that, then you should come to REANIMATE 10 in San Diego, November 13th and 14th. And if you're interested in that, just come to reanimateconference.com. That's reanimateconference.com. All right, enough of that perhaps overly long intro. Let's jump right into this lecture from Jason Bartos. And I will say, if you're listening to this on the audio feed, you might want to watch it in video form because the slides are fantastic. But I think you'll get most of it if you listen and then also come on over to the show notes and actually look at the slide set for anything that is relevant, that a pictorial representation will do better than the audio. So either come watch the video at EMCrit.org or check it out afterwards, the slide set, so that you can experience the full breadth of the lecture. Okay, let's get into it.
That is very, very kind, and I hope to live up to half of what you just said, and that's very, very nice. And welcome to everybody. Thank you for having me. It's great to have an opportunity to talk with you all. I think one of the messages from the last thing we just heard is that no matter what you do, the program, or you'll have a patient roughly 10 minutes at least before your program's set to start. Every part of our program, and I'll talk about all of them today, had a patient hours before the go live time. And so you really do have to be a little ready ahead of time. Now, my point here, as much as I'm going to be talking about our experience, my point is to talk about some general themes of ECPR, some controversies, and some places where we just don't know what to do, but it's couched in our program and our experience. So you'll see that. You may be able to apply it to your local area, but certainly, hopefully, it sparks some thought and consideration. I have some disclosures just around some federal funding related to ECPR, as well as some charitable trust dollars that we also use for our ECPR program in the University of Minnesota in the Twin City metro area. Okay, so some basics on cardiac arrest. 600,000 cardiac arrests a year, 2/3 of them out of hospital, the other third being in the hospitalized setting. People with shockable rhythms do much better. I think that's our experience in everyday life. The reasons for that are probably many, but at least some of them are related to defibrillation, the fact that you have a treatment you can provide in the field as opposed to the others. But the survival for patients who have shockable rhythms is right around 30% nationally, whereas the others are much lower, and the average is around 10% overall. because still, to this day, about 2/3 of the cardiac arrests are non-shockable. What I'll be talking to you about mostly today from our program is patients with shockable presenting rhythms. And the important part is to note that we targeted that group because we thought those would be the people most likely to benefit from ECPR. It turns out that's true as far as we can tell from the data that we have. But at the same time, it leaves an opportunity for the other 2/3 of cardiac arrest still to be addressed in our system and in others. This was our data when we were looking at it back in 2012 and 2013, using data from Minnesota for cardiac arrests all the way from 2011 to 2015, when we finally got the last bit of data, all of the cardiac arrests occurring in our state. It's really important if you're starting an ECPR program to know your data. Know how many patients you expect, how many cardiac arrests you expect. And so when we looked at our data in our state, we had about 7,500 cardiac arrests overall, and about a third of them, again, were shockable rhythms. If you look at the outcomes as they march across the x-axis through the different stages of hospital admission, recovery, and discharge, what you see is that you lose patients at every stage, but you lose many fewer from the shockable rhythm group. So even though you start with a third of the patients in shockable rhythms, nearly half of them, or a little bit more than half, will achieve ROSC. Then you move on to admission, and you lose a few before admission, and then they go down to the point of neurologically favorable survival, which is CPC 1 and 2. That's the cerebral performance category, a nice bedside evaluation of neurologic function. The normalized data is on the right here, so it's a little easier to interpret. So you can say 54% of people in that data set got ROSC in the shockable rhythm group. That's the red line, as compared to 32% in the overall group, which again includes 2/3 of the people in the non-shockable category. But if you were admitted to the hospital with a shockable rhythm, you had a 2/3 chance of leaving the hospital neurologically intact. So that situation where you're being admitted and the post-arrest care certainly is beneficial. You have 2/3 of people leaving the hospital, but you still have a third of the people that we need to optimize that care as well to try to bridge that gap to get them out of the hospital. Now, ECPR is a system embedded in that data, in those patients, in that community. And when you think about the system, you have to think all the way from the beginning all the way to the end. The beginning being recognition of a cardiac arrest at somebody's home, workplace, or community, all the way through activation of the EMS system, cannulation, of course, which we're thinking about a lot, but still after that comes that post-arrest care and even the survivor clinic at the end. And so you really want to think about the entire system, build up every aspect of that system so you can optimize that care for your patients. And that optimization is going to be unique to your local area. So again, I'm going to be talking about the Twin City metro area in Minnesota, but there are likely differences in your area that would actually necessitate different adjustments. Patient selection is something we all come up against, and some of you in this room have seen this figure already. But really, it's a way to think about how you may customize patient selection to your group. So you can be lenient or you can be strict. Most of you will fall in the middle somewhere. If you're really lenient, you're going to take patients. These are criteria used by different programs and different trials in different places around the world. The most lenient goes up to about age 75 in general. May take all presenting rhythms. May take people with any type of CPR, mechanical or manual CPR. And may have no limits on CPR duration. If you're really strict, you may cap it at 60 years old. You may have only shockable presenting rhythms, only witnessed arrest, only people with bystander CPR, and only people that got mechanical CPR with a duration that may be up to 60 minutes. So again, you may land in the middle. You may take some of those from each camp, but that's the sort of spectrum on which different programs exist these days. There are some additional criteria at the bottom that different programs use. Physiologic criteria, which actually we use, and I'll talk about more in a bit. That's blood gas results, PaO2, lactic acid, end-tidal CO2, all options that are data that are available to you immediately at the time of cannulation. And then some groups will use signs of life, whether people are gasping, moving, have pupillary reflexes, or other brainstem reflexes. Again, another way you can try to stratify patients and choose those most likely to benefit from your intervention. But your choice is going to depend on a lot of different factors. And again, these are locally relevant and locally unique. So first of all, your case volume increases the more lenient you are, of course. The more lenient, the more patients you have, the more cases you do. That may be important for you to maintain a critical volume of cases for you to maintain the skills to be able to do this. If you have one case a year in your community, it's going to be very hard to maintain the skills. So you have to choose, to some extent, your selection criteria so that you have enough cases, again, to maintain those skills. That said, the more you do, the more lenient you are, the lower your survival percentage will be. And that's important if you need to talk to hospital administrators, your program, and your community about what your program is doing. But the more lenient you are, the more total survivors you have. So even though your mortality percentage will be higher, your survival will be lower. You're going to have more survivors because you're giving everybody a chance. And there are definitely people, no matter what your selection criteria are, there will be people that you deselect, that you say do not fit your criteria for your program that could have survived. We have people in our program that we've put on as exceptions that have survived despite every criteria we have. And that's just a matter of how this works. But again, the more lenient you are, the more survivors you're going to have. The more procedural experience you're going to have, the more resources you're going to use, and possibly the more revenue your hospital system will have, depending on the discussions and considerations that you have at the programmatic level. Patient selection can also be done in a slightly different way, in a more decision tree type method. So you can customize this to your criteria. This again is based on data from our institution. When we looked at the different factors pre-arrest and data that we would have at the time of arrival, we've got the graph on the left of meaningful likelihood ratio for each of those criteria. So the highest is whether they have ROSC at the time they arrive. CS is cardiogenic shock, meaning that they have ROSC, but they're in profound cardiogenic shock and still needed ECMO. Those folks do the best, and that's the most selective criteria, not surprisingly. If you have intermittent ROSC, meaning you had ROSC at a moment and then lost it, maybe multiple moments and lost it multiple times, that's the next most selective. CPR time after that. And then you have sort of a second tier with lactic acid and bystander CPR, and then a bunch of other factors that are much lower. When we put that through a machine learning algorithm and sort of developed the decision tree, obviously if people had cardiogenic shock, they all deserve ECMO. They have a 79% survival rate. Post-arrest, severe cardiogenic shock, needing ECMO, 79% survival. The rest of the patients go through a decision tree, and we've color-coded this decision tree in our estimation of when patients should definitely be given ECMO, where a program may decide to give them ECMO or not, that's the yellow, and then the red where we sort of think is justified for no program to give them ECMO based on very low survival. So if you follow that decision tree, any presenting rhythm at the time they arrive to you, all these patients started with shockable presenting rhythms to the EMS service, but they may arrive to you in VF, in PEA, or asystole. Doesn't matter what rhythm they present to you in, they're all in that same bucket, and they're all roughly the same survival. If you look at the time of duration of CPR, that's what ATCT is, if it's less than or equal to 45 minutes, they had a 57% survival rate. All those people would get ECMO in our estimation. The other group is 16% survival, which we then further differentiate as to whether they had intermittent ROSC. If they have intermittent ROSC and a lactate less than or equal to 10, then they have a 46% survival rate. That's our yellow category. It's anywhere between 10 and 50 got yellow. If they had intermittent ROSC, but they had a lactate over 10, then they had a survival of 10%, and that we deemed red, big stop sign. If you go the other way and you don't have intermittent ROSC and you have a lactate less than 7, then you still have a survival rate of 33%. And if you have a lactate greater than or equal to 7, then it's a survival of 9%. So again, you can use a more complex algorithm like this. Your data may be slightly different. Again, this is based on our cohort with our patients in our community and our EMS agencies. But this is one method to try to select within that lenient, strict category. So of course, you know ECMO includes a pump and an oxygenator and a patient. Pulling blood out of a femoral vein, putting it back in a femoral artery. That's a patient's growing from in the upper right picture there. The distal perfusion cannula, the blue-topped cannula pointed down the leg. We put distal perfusion cannulas in everybody. The pump that we use, primarily the CardioHelp pump in the lower right, we get a lot of other data from that lets us helps us resuscitate, like hemoglobin levels, mixed venous O2 sats, those sorts of things that we use to resuscitate people acutely. So this is our setup. We use typically 15 to 17 French cannulas, arterial cannulas, and 25 French venous cannulas. Everything is ultrasound and fluoro-guided, and we'll talk more about that. And again, we have some additional data from the pump that we use to resuscitate them. Ultrasound is a must. We don't cannulate anybody without ultrasound guidance. This is because the artery and vein are pulsatile, and both may be very blue blood. So you can't use the cheats we'd normally use. We also care very much about the complications of ECMO, which are primarily access site complications, and you can minimize that with ultrasound and with good vascular access techniques. Now I show a picture in the right here, the lower right, of a artery and vein from a patient who's just in the cath lab, not getting CPR at the time. So you may expect it, somebody getting a lot of pressors may have a slightly smaller artery if it's really clamped down. That said, this is a person in a pretty relaxed state, and a scale drawing of what a 17 French arterial cannula and a 25 French venous cannula look like. So it essentially is occlusive, that 17 French arterial cannula, essentially the size of that artery. Importantly, we cannulate our venous cannula all the way from the groin all the way to the SVC. Those of you here have heard me say that probably multiple times at this point in the different cannulation sessions. This is a CT, a couple slices because nothing's in plane for humans. So if you look at the bottom picture, you have an arterial cannula that's ending right about in the distal aorta. And then you have that venous cannula that starts down there and then goes all the way up to the SVC. That's going to come in, become more important a little bit later when we're talking about LV unloading. Our goal, needle time to ECMO time, is 4 to 5 minutes. Again, my fastest is 3 minutes from door of the cath lab to ECMO start. That's because we had an EMS crew that basically could pick up the patient, set them on the table, and we had a team that was very experienced, very good at going fast, but safely. We want to minimize bleeding and limb ischemia, and we want to use all the guidance that we have. And again, fluoroscopy in the cath lab, fluoroscopy in our truck, fluoroscopy in the EDs where we do this. Everybody's got fluoro as we built it. We want to maximize pump flow. That's how we do it, at least. We maximize the pump flow, but we want to minimize the trauma to the red blood cells. So that's where cannula position is important. We want to be able to pull all the blood that we want. We want to be able to put it into a large vessel. A lot of these folks have coronary disease, which means a lot of them have peripheral vascular disease. And if you have an arterial cannula that's pumping that blood at whatever flow rate through this diseased iliac artery, you'll get a lot of trauma to those red blood cells, a lot of hemolysis. So that placement of the arterial cannula, even though we don't think about it much because you just put it in as far as it will go, ideally it would land in the distal aorta, where it's your largest vessel of opportunity. And of course, the ultrasound guidance we've already talked about. So these are a couple pictures from the fluoroscopy. Again, the benefits of seeing what you're doing. So the wire conformation on the left, that's a shot of the pelvis. You can see those wires split. Very reassuring that your wires are where they're supposed to be, at least at that point. And then this is a picture on the right of the venous cannula. So there's actually a coronary cannula catheter too, but the venous cannula, which is right here, passing through the right atrium, landing in the SVC. I would not personally try to put a venous cannula into the SVC without fluoro guidance or an echo guiding it, because that wire, no matter how stiff the wire is or how flexible it is, likes to curl in the right atrium. And if it curls in the right atrium and you put your venous cannula up there, there's a serious risk of perforation of the right atrium. So the fact that we can see what we're doing, again, echo would be okay too, but the fact that we can see it with fluoro gives me a lot of confidence passing that up there to maximize the flow and everything for our patients. So this is a video. Some of you had seen this already. There are two goals of this video. I want to run through the steps again with you. Again, I also want to show you that it's doable within 3 minutes, because this may seem like a long time as you're watching it, but actually it's still only about 3.5 minutes, this whole video. So this is Dimitri Yiannopoulos in our cath lab. I'll be next to him in a second. We started, this was our maybe 15th case. For the first 2 years of our program, we were both on call 24/7. We did every case together so that we could make sure that we both got experience, but also so that one of us could essentially be running the code while the other person was focused only on cannulation. So as you're doing a new skill, you're learning a new skill, you're bringing that out and you're going to perform it in a high-pressure circumstance, it's very important to be able to focus on that one skill. And doing other things that distract you is not ideal. So we would have two of us, one of us running the code. Once the code got underway, we would then pop in and help with the procedure. So I'm now standing next to him as he's putting in his needles and wires. So you can see already he has a needle in the vein and a wire going down into the vein. He just put a needle in the artery. There's going to be a wire going through that shortly. He's confirming the placement of those two wires with fluoroscopy. He's looking for that picture that was on the left, the split of those two wires in the pelvis, making sure that they are in fact going one in the vein, one in the artery. Then the dilation begins. The entire time the Lucas is running, the Lucas doesn't get stopped for anything. So at this point, there is no intubation happening. There may be meds given, but no shocks. everything is meant to focus on the ECMO, and if we can get it in 3 minutes, it's really going to be more beneficial than anything we can do with the rest of ACLS. This person getting CPR now for about 50 minutes, 55 minutes at the time of their arrival. So anything in ACLS is the 10th or the 11th time it's being done for this person's resuscitation. So now you can see the venous cannula, large and spear-like, but over the wire, so safely placed. I'm going to run up to the SVC, confirmed with fluoroscopy again. And then we'll clamp it off and get ready to put in the arterial cannula. You can see around the patient too, you occasionally see people running around. So this is in the cath lab. It's sort of a unique and optimal experience. You have 2 techs, 2 nurses, a respiratory therapist, a perfusionist, an ECMO specialist, and some onlookers. This early in the program, we had a bunch of people come just to see what was going on. So it's a whole team, but the team is still choreographed, and it's an extension of what they normally do in the cath lab and in STEMIs. So it was somewhat of a natural extension. But of course, there are skills that need to be learned for everybody. But to some extent, just the layout of the room was standardized. The rooms are set, again, places everybody works. So the nurses tend to hang around the head of the bed, running around with meds to the Pyxis and back. The ECMO specialist perfusionist would be across the table from us. We were always on the right side of the table, always near the groins of the patient. The tech, where one of them would be next to us on the right, and everybody sort of knew their place and was in their geographic zone. There was no bumping into each other. There was nothing that was unexpected in that sense. We could always have the routine environment that we were used to working in. So now their artery and vein are both in, and Dimitri is asking for tubing from our perfusionist. So when I watch this video in retrospect, I see all the imperfections. I see the things we've already improved. As has been said, we dwell on the minutia as well. It's really critical to look at every step. And the fact that this took an extra 30 seconds to get the tubing is something that came from an inexperienced perfusionist because we were early on. You know, they cycle through. This person hadn't been in one of these before, so they didn't yet anticipate that move. But every person in this team does so many now, and it back then had cross-trained where, for the most part, they could anticipate the steps. But still, things are just a little bit slower at the beginning, and that's okay. You try to optimize the team as you go. So at this point, cutting the connectors off the tubing, and we'll connect it with fluid-to-fluid connection, and we will exclude that air. Again, Lucas going the entire time. Now this patient's going to recur in a future slide related to the trauma of CPR. So keep your eyes out for that picture. But this person had a bit of an interesting path through their recovery, but did well in the end. So we will talk more about that. So now the moment that we all wait for when we have somebody cannulated, the grand blue to red transition and the blood return. So they're right now unclamping the side on the perfusion side, getting the blood flowing, and then it will come back red. You will notice he's sitting there with a clamp, waiting for the moment, just in case a little bit of air comes out of the oxygenator. There's always a little concern, and it happened once to us, that there's a little bit of air still in the oxygenator that hadn't been flushed out by spinning it up, and that gets pushed through. So luckily, patient went on, and again, did well eventually, but we'll talk about that in a little bit. ECMO has the benefit of stabilizing hemodynamics and returning blood flow, providing essentially artificial ROSC. You can guarantee ROSC with ECMO. But it also has the benefit of stabilizing so you can do the next step, which is treating the underlying etiologies. And some programs fall short when they don't have the ability to get patients into the next step of treating the underlying etiologies. So I would suggest that you, if you're not an interventional cardiologist yourself, get your interventional cardiologist on board early. Because in our case, 84% of our patients had severe coronary artery disease, split evenly between 1, 2, and 3 vessel disease. Those things need to be fixed to treat the underlying etiology, and we think, though we don't have direct data for, but we think to promote cardiac recovery and survival. If we don't find coronary disease, still to this day, we do a pulmonary angiogram in most of those patients, looking for PE just in case. We find very few. But again, this is a shockable presenting rhythm group, so not necessarily the classic PE patient. So we started our program at the University of Minnesota. Every patient had to come to us, and that was back in 2015. It was an extension of the Minnesota Resuscitation Consortium, which had already existed, to unify various practices around CPR in the Twin Cities, one of them being taking patients with shockable rhythms to the cath lab. So really already brought together most of the EMS medical directors and most of the hospitals in the Twin Cities. It was a natural extension that this would be the next step for that group. Really had three priorities. First was mobilizing patients from the field quickly. Second was providing that hemodynamic stability provided by the ECMO. And the third, treating the underlying etiology. This was what all the hospital systems and EMS medical directors agreed to. So we did it in the cath lab, brought them to us. And this was the criteria we used, the field criteria used by the paramedics to select patients, ages 18 to 75, refractory arrest, again, starting with presenting shockable rhythm, but they could be shocked into PEA or asystole. We all required they all would be fitting within a Lucas CPR device because we didn't want them transporting patients with manual CPR. And we requested that they estimate the travel time less than 30 minutes. So I learned at that point that paramedics are very optimistic about drive time. It turns out some of them will come from about an hour away, but it's possible that it would have been less than 30 minutes. They just underestimated traffic maybe. But either way, we did not select at that point. We asked them to think about it ahead of time, but we did not turn down patients depending on the time at which they arrived. We still brought them all in and did the rest. Importantly, though, we did use physiologic criteria. We still do. The PaO2 greater than or equal to 50, the lactic acid less than or equal to 18. So it's pretty liberal criteria. But still, even with those criteria, we select out about 18 to 20% of the patients. So the failed resuscitation, maybe they aspirated, maybe they had some other issue that prevented them from getting air or gas exchange or poor perfusion in that lactic acid. But either way, those patients still get excluded from our program. If they do fit those criteria, we cannulate them. And then once we get them cannulated, coronaries addressed and fixed, and hemodynamics sort of stabilized, then the clock begins. We have 90 minutes to get them into an organized rhythm. It can be VT. It can be any supraventricular rhythm. It just can't be ongoing VF or asystole. Our deal with our hospital from the beginning was if those are still the rhythms, we will not admit them. They will unfortunately die in the cath lab. It's a very small number of patients. The vast majority were able to get into an organized rhythm within that 90 minutes. As cath labs go, that's a long time to be dedicated to doing nothing but medical management, but it is something that is important to, again, be that threshold to get people that have a chance to survive up to the ICU without taking people up that don't have a chance. Using that exact same protocol in every detail, we performed the arrest trial in the Twin Cities. This was completed sort of in the early days of COVID, but published in 2020. And it showed with 30 patients that we had significantly improved survival, just survival overall, and then neurologically favorable survival as a secondary endpoint with use of ECPR. 46% survival in the ECPR group versus 6% of survival in the standard ACLS group. And if you look out beyond that 106th day, 0% survival in that ACLS group. That one person that survived in the ACLS group was trached and pegged, which tells you, I think, how hard we pushed for every single patient no matter what group they were in. We were not blinded to which group they were in. We obviously knew if there was an ECMO machine hooked up to them. But we still pushed for every aspect of treatment, trying to get everybody through it. And that one person, unfortunately, did not have a good neurologic outcome, and they died after their 106th day. But all of the ECPR patients survived as long as we have the data for them, all the way out as far as 210 days. So the reason I mentioned only 30 patients, we had actually planned for many, many more, but it was stopped early by the DSMB because it was unethical for us to continue to randomize people to standard ACLS. In our community, with our program, we had to give people the option of ECMO and ECPR. Otherwise, we were being unethical, as deemed by that board. So that's why we stopped early, because it was such a profound benefit. Despite that, when we look at our data, and this is including data, again, from the whole cohort, from our whole program, and you saw this, folks in the room saw this a little bit ago, or yesterday, time is so critical. So if you look at the blue bars, that's our ECPR group. If you look at the orange bars, that's the amiodarone arm of the ALPS trial. You can consider it standardized ACLS. Very well-trained paramedics providing ACLS with amiodarone as the antiarrhythmic of choice. In that group, the ALPS group, they had 66% survival at 0 to 9 minutes of CPR, and every 10 more minutes of CPR that was added dropped survival by 17%. In our group, 29 minutes or less, 100% survival. It dropped down by 25% every 10 minutes to the point where it sort of leveled out around 15 to 20%, extending all the way out to 98 minutes, which is our longest survivor. So time absolutely critical. Every minute, 2.5% mortality, 2.5% less survival for every minute that goes by. So the question then became, we did the randomized trial, we've got this program going on, but how do we get to people faster? So you can get to people in a variety of ways. You can bring them to you, that's what we're doing in the cath lab, or you can go to them, but you still meet them in the middle. So the emergency department model is what we brought on next, and I'll show you that in a second. But we're basically meeting people halfway at one of 3 emergency departments that are sort of circumferentially around the Twin City metro area. It's still C-arm in the ED, so we still have fluoroscopy, we still have the ultrasound, we still have our entire setup from the cath lab, just a slightly different team with ED, physician, nurses, RTs contributing, and our team doing the cannulating. You can also completely go to the pre-hospital setting and provide the care there. You can fly out, you can take a big truck, I'll show you pictures of that. You could pull out your tarp and put people on ECMO on top of that. That's the Paris model. And each of them are, again, focused on their community, the resources that are available, the skills of the people involved, and where you find the patients. You got to tailor it to your local environment. So in December 2019, we rolled out our ED-based ECMO cannulation. In Minnesota, COVID really hit about March of 2020. So we had 4 months where that program was live, running, and great. And here again, we did get our first patient about an hour before our start time. We transport ourselves to the emergency department with lights and sirens in one of these vehicles. We meet EMS at that emergency department. So they bring their patient, we bring ourselves, and then we cannulate them in the ED. Again, fluoroscopy with a C-arm, fluorocompatible table, ultrasound, the whole thing. So if you look at the Twin City metro area, and I'm not expecting you to know the geography of the Twin Cities, but just if you pay attention to the circles only, the red arrow is the University of Minnesota. Around that is a 30-minute drive window, roughly, with the blue circle. With those 3 emergency departments, we actually expanded it to those 3 orange circles. So we really got a lot more reach, but we also got to the people faster that were otherwise in the blue circle, but now closer to one of the emergency departments. So we accomplished both of those goals. And what we saw is a huge increase in the numbers. So in the first 4 months, pre-COVID months, we had 58 patients now in that program. That was basically our yearly, or even a little higher than our yearly number before that, because now we had such further reach. But the map on the left also shows you what I was saying about the optimism of drive time for paramedics. Each of those black dots is a patient, and you can see how far out the circles they are. They were coming from far away for some of these folks. But even with that, and with the 58 patients coming to those emergency departments, we still had a survival, a neurologically favorable survival, of 43%, maintaining effectively our survival that we had at our university-based program. Then we had intermittent closures and things for COVID. It was a very rough time. And then we reopened everything finally in May of 2022. Everything was back online every day with the expectation that we would not be closing anymore. And then in July of 2022, we rolled out our truck. So the thing about the truck is that it's mobile, which means that we can go basically anywhere, and we can meet the patient anywhere halfway. So they can drive from far away. We're not necessarily driving to their living room, because that actually would limit us more. We can drive to a middle ground, have them come to us, and we meet them, and that means that we've got one giant circle now, which is the truck. This is a few pictures of a truck. Again, we still drive our little SUVs to get us to the truck. The truck is housed in a firehouse. They meet the EMS rig at that defined location, and we meet them there as well. You can see a couple pictures from the back, but here's a video of the back. So you can see the floor of the truck is about shoulder height. We need a lift to bring the patient up into the truck on a gurney, an EMS gurney. We then bring them in, we convert them or move them over to this fluorocompatible table. The truck, again, receives the call. We all receive the call from our centralized dispatcher. We all meet at that centralized location. This is a practice run we were doing with paramedics with a mannequin. But we, again, lift the patient in, load them in, bring them on the fluorocompatible table. Then we'll move the table sort of kitty corner or at an angle so we can fit everything in. Everything from that table back is sterile. Everything from the table to the front is an area where we can have people moving around the C-arm in a non-sterile fashion, handing us supplies, doing things like that. We still have the C-arm for fluoroscopy. We still have ultrasound. You can see on the left side of the screen here is a big screen where our fluoroscopy and everything will come up so we can see it easily in the room. Nobody's squinting. This is that first picture is the first case. This is the second case. You can see many fewer people. It's much more comfortable, but first case, everybody packed in to contribute and to see what was happening. We built the truck so that we'd have full telemedicine capabilities so that theoretically, just like we did in the first cases in the cath lab, we could have one person at home or in their office at the university watching screens to run the code, while one person could be in the truck focused on cannulating. And that one person in the truck focused on cannulating would also have the assistant, who are flight medics or nurses. They're helping to do that cannulation. They're all cross-trained. They could theoretically do the cannulation themselves, but really what they do functionally is they are the wire assist person. But they can anticipate all the steps and all the supplies we need. Now you can see there are the different parts of the screen. This is from the first case. You can also see that in the upper left is a Zoll that's turned with the back toward the camera. That's because it's the first case and the firefighters really wanted to see what the Zoll showed. So we learned something from every single case and optimize it every single time. We have now 16 cases in the truck. I show this very intentionally because nobody is perfect. Our cases still are a work in progress. Even with the very well-developed ECPR program, you're going to have the same thing. And we embrace that change. I mean, these are all things that we can learn. And the beauty of the telemedicine component is actually now we can review all of these cases and everybody can learn from them. So if you have the opportunity, whether it be GoPros or whatever the options are for you with privacy standards in your hospital and in your program, I would definitely take advantage of that. It really does help refine the process. And it's amazing what you don't remember, but that you see when you look back and what you can improve. The key in the bottom left there, that's the view of the cannulation. Again, the idea is the person from home could be watching that, maybe even giving some tips if the person with the cannulation role is not as experienced. But it's the same steps. There's nothing different. Our goal with the ED program, or initially in the cath lab, then the ED program, then the truck, was to do everything the same in a familiar environment where we had control of the resources and the environment. So we still have, again, fluoroscopy and ultrasound, but we also do all the steps the same, and we have all the same tools. The fluoroscopy in the upper right there, you can see the wire go up and across, and you'll see the cannula come up in a little bit. The ultrasound is here. You can see that the patient's head has a circle around it for the purposes of privacy, but that's so that we can actually watch the airway management stuff after we're on pump. So we can see that from home as well, and we can see the CardioHelp. There were some devices that we could pipe in directly, their data and everything, into our truck, and others that we just had to have a camera watching them because we couldn't get the data extracted with the technology. So now we're going to connect the tubing, get the flow going, and everything's essentially, again, the same as any other place that we cannulate. So now they're on pump. What do we do next? And this is, again, data that we've gathered over time and the way that we approach things. But this is the classic model of post-cardiac arrest syndrome. This is what you'll find in the review articles and in the books. It's a combination of brain injury, myocardial injury, precipitating pathology, meaning, in our case, coronary disease in most cases, and SIRS response, profound vasodilation. Unfortunately, when you get CPR for an hour, you have everything else damaged as well. It's pan-system organ failure, and it's trauma, all at the same time. So we have to deal with all these things, and you need a very detailed system, a 24/7 multidisciplinary system where everybody's on board with considering that patient to be viable. Your nephrologists are willing to do dialysis, your surgeons are willing to do surgery, cardiologists are willing to fix coronary disease and stent. Everybody has to be on board with these things so that patients actually have the full chance of survival. It doesn't matter which end organ you look at, they're all injured. Your LVEF will start very low in many patients, but most of them come back. In these graphs, the various time is on the x-axis, the various markers are on the y-axis, and all of them are split into three groups. The blue is the survivor, the red is people who die of some other cause non-brain death, and the green ones are the people who die of brain death. Presumably, though this is an assumption, the people who die of brain death are the most injured from their cardiac arrest. And that's what we tend to see. They have the most dramatic markers of injury of any of the groups. But all of them are injured. All of them have abnormalities, and most of those abnormalities, if you have enough time on pump and stabilization, will improve over time. But some of those patients obviously die, especially the folks with brain death. Here's the trauma. This is our patient. This is the heart of our patient who is getting CPR in that picture. What you see is a large red circle. That's a quarter-size hole in his right ventricle. That did not materialize for the first 4 hours or so. So he was doing really well on pump. We were chugging a little. We needed some preload. We were actually pulling every ounce of blood out of his body with the ECMO circuit and pumping it back, providing him all that support. And he was doing well with that. Once we got him more fluid resuscitated, then he started to have some blood go from the right atrium into the right ventricle. Not a ton, but a little. And when it went to the right ventricle, it went right out that hole into the pericardium. After about 4 hours of stability in the ICU, he started to chug, and what I call perma-chug, meaning that he not only chugs in a way that you can turn down the flow and the flow starts to come back, but actually it just stops. It's really hard to get the flow back. You have to really pound the fluid in. And when that's happening, you got to look for causes. So we put a probe on the heart, or on the chest, large pericardial effusion, tapped it, frank blood. At that point, one of the hallmarks of our program came into play. Our cardiac surgeon came in the room and said, "Do you think he has a chance at surviving?" That was the only criteria he had. He did not worry about the fact he had an hour of CPR and is on ECMO. He didn't worry about the fact that he's now in tamponade and having a hard time with flows. He just asked, "Does he have a chance at survival?" We said yes. He said okay and took him off to the OR. Didn't know what he'd find, although there's a pretty good guess there's going to be something bad. Found this quarter-size hole, patched it, brought him back out. From then on, he was incredibly stable, did really, really well. 2 weeks later, he was in the hospital lobby playing the piano. And 1 week after that, went back to his church where he plays the organ. So this guy, again, did amazingly well only because one of our surgeons was willing to look past every indication of outcome that most people would use and was willing to provide the services he could provide, and only he could, at least compared to us. Certainly there's a group of surgeons, but he was the one on that day. He was willing to provide that service and got this guy through it. So it's a testament to the team. And there certainly are other aspects of trauma as well, certainly some people needing chest tubes, some abdominal bleeds. We have general surgeons who will open abdomens for us as well, but that's much more rare. So all of these things need to be dealt with. Recovery, even with all those services, is still a marathon. So if you look at our 478 patients, last time I sort of compiled the data, we still have 39% survival for the people who are admitted to the CICU, 37% if you look at the people who qualified for all the treatment. And yet, if you look at the upper right, just for the survivors, that data in the upper right graph is just survivors, all of the survivors are off the pump by the 10th day, but only half of them are following commands by a week. The other half are following commands much later. They do get extubated generally soon after they start following commands, but they have long hospital stays. It very much is a marathon. That said, if you don't do well, especially since many of these people have brain injury, that actually ends quicker. So the bottom right is those people who die, and half of them die within the first 4 days. Those are the people with catastrophic brain injuries. They herniate, and they no longer are in the ICU at that point. But there are some people certainly in the ICU longer who still end up dying. The primary cause that I've mentioned of death is neurologic. There are two types. There's brain death and there's anoxic brain injury. The brain death is actually the majority of those two groups. So it's 42% of people that die will die of brain death. They will herniate and die. 31% have anoxic brain injury. Those are the people who take much longer to sort of differentiate themselves. And then there's a smattering of other causes. This is my favorite graph. You've already seen a beginning of it. This is actually a newer, updated version. And it turns out, this is, again, our experience. We had the first version. You probably don't remember the details that you saw yesterday. But what you would have, if you look back, it's actually much more left shifted. But once we saw how late people were waking up, we were willing to wait even longer and push it out even further. So now, we routinely have patients who are 3 or 4 weeks in the ICU still in a coma, because we know that some of them will wake up. So this data, on the x-axis is the days of their stay. The y-axis is their likelihood of having neurologically favorable survival. And this is for people who are undifferentiated, meaning that they're not following commands, but they have not been declared dead. Most of the people that have been declared dead are declared dead for neurologic reasons, but the other smattering still plays a role as well. So if you look at the very beginning, you have 40% chance of neurologically favorable survival on day 0, basically in line with our overall cohort. Because people die early of the brain death and other neurologic causes, if you survive the first day or two, your chances of survival actually goes up. But then it starts to dwindle over time. But still, if you look at 25 days, 20% survival, neurologically favorable survival. So we have people in a coma out 20 days, 25, and even 30 days who are waking up neurologically intact eventually. Their recovery is long, but they do well, and they get out of the hospital, and they lead happy, productive lives, even after such a long stay in the ICU. So there's some controversies that I want to touch on and our experience as it relates to those controversies. The first is, again, back to the data that I showed at the very beginning in terms of our area. So neurologic favorable survival is 32% if you're in the shockable rhythm group. If you're admitted to the hospital, it's 59%. But I showed you our selection in that machine learning model. The people that come in with ROSC, but with cardiogenic shock, 79% survival. So this puts into question whether ROSC is really the thing we should be fighting for in the pre-hospital setting. I'm not saying I have a definitive answer, but if you have a better chance of surviving with ECMO and cardiogenic shock than you do in the overall cohort, which includes a lot of people that don't have the cardiogenic shock that comes with their ROSC, to me it suggests we're not using ECMO enough in the overall cohort. That perhaps if we could get ECMO even earlier, instead of waiting to get ROSC, because this is the debate, right? It's like, when should we pull the trigger on ECMO? Should we do CPR in the field for 15 minutes and then move? Should we do it for 30 minutes and then move? This is a debate you have to run with your EMS crews when you're thinking about your programs. Perhaps we should be doing it at 5 minutes, because if you move people at 5 minutes, we can get them on pump within 10 or 15. They're going to do much more close to the 79%, maybe even better, than they would to the 66% they were doing before. That, of course, from a resource utilization and all the things I talked about in terms of patient selection, drives the thing way off the charts. But this is, and again, it's controversies, but this is where I think the data is sort of pushing us. If you think about it just intuitively, what is the best thing you could do for a patient having a cardiac arrest, any type, shockable or not? Giving them perfusion would fix it. If you could give them perfusion 30 seconds after their cardiac arrest, you would have 100% survival in all likelihood, or close to that, unless the underlying etiology itself was fatal beyond the perfusion problem. So yes, you can't obviously do that practically, but can you move up the time of ECMO to such a point where you are getting close? I think that's where our future goes with this. Cardiac arrest, the treatment of cardiac arrest is going to be more of an ECMO treatment than anything else in the future, is my prediction. Okay, LV unloading. Everybody asks about LV unloading because everybody talks about LV unloading. That said, if I asked you intuitively, again, just intuitively, what do you think would happen to the intracardiac pressures, the blood pressures in the ventricles, if you bypassed the heart with 5 liters of blood or 4 liters of blood per minute? I think most of you would say intuitively there would be less blood in the heart because I'm bypassing it with all that. Therefore, the pressures would actually go down. That's what the intuition would say. However, there's a lot of discussion out there about the pressures going up, counter to your intuition, and actually counter to our data. So I will show you that in 1 second. But first, I just want to give you some perspective of the data I'm talking about, because we have to be very specific. So in our data, in our cohort, 46% of people get ECMO only. That's the only hemodynamic support device they get the whole time. 53% get a balloon pump in addition. If you look at LV unloading devices, balloon pumps are listed. In fact, they are considered to be effective LV unloaders in the data and the meta-analyses that are published related to LV unloading. So if you believe that, if you believe a balloon pump is an LV unloader, okay, 53% of our people are LV unloaded. But I will tell you, balloon pumps are the worst LV unloader you can have. It's about a ½ liter per minute if you have a good heart. And if you really need the unloading because you have a very poor function, it's going to be even less than that. So I would argue they're not a very effective unloader. I think they're a good stagnancy preventer. They create some movement of blood. They hopefully prevent clotting in the ventricle and on the aortic valve, but I'm not so sure they actually unload the ventricle very effectively. But it's there. That's for you to judge. We have very few people that got Impella. All of those came from the very beginning of our program where we put a couple in and we never did again after that. Okay. Again, also keep in mind how we cannulate. That venous cannula is all the way up in the SVC, so we are very effective at pulling blood into the machine and unloading the heart from the right side. So I know all of you really are excited about pressure volume loops. How could you not be? But this is an example of a pressure volume loop on the left. Some things to remember. Stroke work is the area of the curve, of the shape. So if you change that area, you change the stroke work. The afterload is this sort of left and upward directing line. The negative slope of that is your afterload, so the steeper that gets, the worse. And your contractility is the slope of that ESPVR line heading to the upper right. So those are the things that we need to think about when we're thinking about these pressure volume loops and different devices. There's another example, cleaner example in the middle, just for your reference and what's happening with the different valves. And then on the right is an example of what happens with congestive heart failure. So the blue pressure volume loop is normal. The orange is cardiogenic shock, and the far red one there on the right is congestive heart failure. So your volume, which is the x-axis, is going up, so it's shifting to the right, and your contractility is coming down because they're in heart failure, so it's dropping. This is what you will read about what ECMO does to your pressure volume loop. So the middle, again, is what I showed you just a second ago. The ECMO is on the right. The literature would say that your baseline is the blue one. The orange one is what low flow ECMO does, and the red one is what high flow ECMO does. Shifts you far to the right volume. Again, counter to what the intuition would say, which is the volume would go down because you're bypassing the heart with all that volume. But you have a high flow in this prediction, discussion in the literature, shifts to the right. And the contractility shifts a bit as well because your afterload is supposed to be increasing. This is what our data would say. And we now have 20 patients that we've done invasive hemodynamic monitoring on as part of an NIH study. These are the first 6 that we did. So we have TE probes, we have the Swan catheters, LVDP measurements, and we're doing 3D echo in addition to measuring all the pressures as we're turning down the ECMO in the cath lab in a controlled setting with all the anticoagulation and all that. People are consented, or patients' families are consented for this, and we do it as part of the research study. They all show a similar trend. I mean, they're different individuals, different scenarios. They have slightly different magnitudes of change. But what you'll see is the blue pressure volume loop here is high flow, and the red one is actually low flow. So this, more in line with your intuition, when you turn down the flow, the volume of blood through the heart goes up. So now it shifts to the right. When you turn up the flow, and we can actually watch this on the echo, when you turn up the flow, the LV decompresses. The LV does not distend. The LV decompresses and gets smaller. When you turn up the ECMO flow, you are bypassing the heart more. This would be similar to what you'd expect with a tandem heart, with LAVA ECMO, all the things where you're draining things from the left atrium, except we're draining it from the right atrium, and the SVC and the IVC, all simultaneously from the right side. So again, each and every curve shows the same trend, slightly different magnitudes, and shifts over. Now that you might say, well, the heights are different. That's true. That's blood pressure changes. So again, the pressure's on the y-axis. So if we don't do a good job of equalizing the blood pressure, meaning that when we go to high flow, we don't drop our pressors right away, or we don't wait for them to be dropped far enough, or we don't give vasodilators if these people aren't on any pressors, then yes, the height of that curve will change. But really, the right to left shift is based on that unloading that we're doing with the ECMO itself. Okay, next controversy, early prognostication. Obviously, this is very resource intensive. We would love to be able to know on day one whether people are going to do well or not. Obviously, that's what patient selection criteria are about to some extent before you ever get on pump, but they're imperfect as we've discussed. So we want to have better prognostic abilities, and for that we have numerous things that we're measuring. So this is just neuroprognostication. We've got neuroimaging, clinical exam, EEG, biomarkers, and NIRS, the near-infrared spectroscopy. To the biomarkers, the troponins of the brain, this is neuron-specific enolase and S100B. What we see is the people who do poorly, CPC 3 to 5, compared to the people who do well, neurologically favorable, CPC 1 and 2, drastically different biomarkers, and those differences increase over time. So if you check at admission, ICU admission, you have a significant difference, but that difference escalates if you go to the 24-hour mark. This can help to differentiate some good survivors versus poor survivors or people who are going to die. Neuroexam is pretty rough. So things that people mention, I mention these because you'll get calls. I get calls almost every day about this patient's posturing, this patient's having tremors, this patient's got a roving gaze, all these things that we need to know how to interpret. It turns out most of them are just really unhelpful. Posturing, I'm not a neurologist, so this is the cardiologist understanding of why posturing would be different in this population. If you're starting healthy and you start posturing, your trajectory is bad. Obviously, it's cardiologist approach, right? Trajectory is bad. If you start dead and you start posturing, your trajectory is good. Things are actually looking up for you, right? So you have to think about the perspective of where you started. You started at dead. So I think in the end, it probably washes out both ways. It's just unhelpful, but you really don't want to overreact, because when they call you and they say this person's posturing, what they're trying to tell you is their brain is injured and in really rough shape, and you should really talk to family and think about withdrawing. That's the inference. But the idea is to take that step back and say, I hear you, they're posturing. We don't really know how to interpret that in this population, and it may actually be a good sign. Tremors, also unhelpful. Seizures are bad, but some people have tremors that are not seizures. And so myoclonic jerks, also essentially meaningless in this population unless they're triggered by a seizure. Roving gaze, also unhelpful. A lot of people have inappropriate tachypnea as they're waking up. It's like their brainstem wakes up in parts, and the part that's triggering breathing wakes up first. And they just breathe 30 or 40 times a minute, nothing you can do about it. You can't sedate them because that'll keep them from waking up. So you just have to ride it out. You have to convince family and staff that it's okay, it'll work itself out. And it does. They wake up, they stop breathing as fast, and they're fine. It's actually often a good sign. GCS, completely unhelpful, not because it doesn't correlate, because it does, but because there's so much overlap between the good and the bad. So you just can't use it to really guide much. Brainstem reflexes at 24 hours is a pretty meaningful thing. That said, brainstem reflexes at the beginning, not so helpful. If their pupils are blown, it doesn't mean they're not going to do well if they come back within 24 hours. So when you're in the midst of the cardiac arrest, oftentimes the pupils are doing nothing. And that's not a bad sign necessarily. But if they aren't back within 24 hours, that is a bad sign. So I mentioned the NIRS. They actually don't correlate so well on a population level to outcomes for these patients. You can use them for monitoring for other things, bleeds, strokes, perfusion, but really the numbers do not really correlate with outcomes, at least in our data. Again, these are all from our data set. Cerebral edema on the initial head CT is very bad, basically a 100% death rate so far in our population. I'm still looking for the exception to that rule. Anoxic brain injury does have an exception, but it's still very bad. And that's, again, on the admission head CT, not necessarily a day or two later, but it's at the very beginning, because those injuries tend to get worse before they get better. And an isoelectric EEG at 24 hours, also very bad. Flat. Not diffuse encephalopathy slowing, which is probably what my EEG looks like a lot of the time. But this is flat EEG. Okay, so in the summary, this is everything from the beginning. ECPR is absolutely a system of care. You have to think about every aspect of the system. EMS, everything you do in the hospital, and clinic after. You have to select your criteria based on what your system can handle, which means your criteria will probably be different than mine, different than everybody else's, but they need to fit your system, and they can change over time depending on what your needs are and what your resources are and all of that. You need to be able to cannulate fast but safe, because all the side effects and adverse events impact your survival. You need to be able to treat those underlying etiologies, whatever they are, whether they be coronary disease or other things, but of course in the shockable population, coronary disease is very common. You have to be able to treat the pan-system organ failure, and you have to be willing to stick it out to have it recover. What I didn't talk about, and I'll just mention here, is organ donation. There is, for the people who don't survive, of course, we're pushing for survival for everybody out to a month. But when we have a person who is going to die, organ donation is becoming an increasingly accepted option. The transplant programs are becoming more willing to take organs from these patients. And it's actually giving some families some solace that something good came from this whole situation. Recovery is very prolonged for the people who are going to do well, and it's difficult sometimes to differentiate the people who aren't. But when the people who do recover tend to recover, again, neurologically favorably, they tend to do very well. It just takes time. But we definitely still have controversy, still have data we need to gather, understanding. So this is going to be an exciting field for the next 100 years or so. Buckle up. It's going to be a great place to do some work and gather some data. So track your data as you have your programs. Make sure you know what your data shows and your patients show so you can learn for yourself, but also you can teach me what I'm supposed to do better. And thank you all for your attention. And this is our survivor dinner we just had about a month ago. I would highly recommend that as you get programs up and running that you have these survivor dinners. It's incredibly uplifting, and it makes a lot of firefighters cry, which is actually quite impressive, these big, intense people that are just so touched by what you're able to bring for them, because they've worked so hard to get these people through that phase that we actually give a lot less credence to than we should, that pre-hospital phase. So this is about a third of our total survivors that were able to show up this year. Our first one post-COVID. It was very exciting, and everybody was very happy. So thank you.